Ladies and gentlemen, please welcome Dr. Mark Michelson.
Hi, good morning, everybody. It is my pleasure to introduce Dr. Scott Halpern, the presenter of this year's Aki Grenvik Honorary Lecture. Dr. Halpern is Associate Professor of Medicine, Epidemiology, and Medical Ethics and Health Policy at the University of Pennsylvania, and a practicing critical care physician. He's the founding director of the Palliative and Advanced Illness Research Center, which generates evidence to advance policies and practices that improve the lives of all people affected by serious illness. He's also a member of the steering committee of Penn's Center for Health Incentives and Behavioral Economics, known as CHIBE, after serving as its deputy director from its founding in 2011 to 2017. This morning, Dr. Halpern will present the Aki Grenvik Honorary Lecture titled Using Default Options and Other Nudges to Improve Critical Care. Please join me in welcoming Scott.
Seems so formal. Do we have to do we don't have to do a picture? Excellent. Thanks, buddy. Thanks so much, Mark. It's really a pleasure to be here. Big room. Thank you all for sticking around for Wednesday morning. So, I don't have too much in the way of disclosures to kick off. Sources of funding, paid consultancy to the American Board of Internal Medicine Foundation's Choosing Wisely campaign. We do a lot of work with some external research partners who provide some in-kind support. So I'd like to start out today telling you about a patient. This is a patient that I cared for as a newly minted critical care attending. It was my first rotation in the medical ICU at Penn after being a fellow and resident there. Had known the unit for a while, but becoming a real attending was a new experience. And this patient was one of the first I cared for during that first rotation. I'm going to tell you a little more about him in a moment. But I want to start by mentioning something that's probably so obvious and common that it doesn't even come through on this picture, which is simply the fact that the head of his bed is elevated at 45 degrees. So, makes sense, right? He's mechanically ventilated. Regardless of what you think about the strength of the evidence in support of head of the bed elevation for mechanically ventilated patients, it's obviously a common practice, almost routine. And yet, when I was a resident at Penn, all of the beds started like this. And in fact, not only did they start like this, which of course makes sense to get patients from the gurney over into the ICU bed, but a physician had to write an order to elevate the head of the bed. Now, why would that be? Elevating the head of the bed is presumably beneficial for the majority of at least mechanically ventilated patients, and probably not harmful for almost anyone, with perhaps the rare exception of a stroke patient. So why would it be that you had to write an order to elevate the head of the bed, rather than that being the default practice, and then you as the physician could write an order to flatten the bed for those few patients for whom it would be appropriate? This is the idea of a nudge, right? It's a decision-affecting feature of the choice environment that neither restricts any choices, you could have the head of the bed up or flat, and doesn't change materially any of the incentives. It's been written about in eons of books at this point. These are just a few. And this is the essence of the concept that I think holds great potential to really transform critical care. So now a little more about this patient. He went by Big Nat. Nat was short for Natale. He was a first-generation Italian-American. Big Nat had a bad cancer. He had been in Memorial Sloan Kettering and then down to Hopkins before he landed in our medical ICU. Big Nat also had a never say never family. He was 60 years old, had been married for 40 years, 4 grown children, one of whom went by Little Nat. And Big Nat was in florid septic shock. 3 vasopressors, an antidysrhythmic. He had overwhelming ARDS on the limits of mechanical ventilation, acute kidney injury that had progressed to anuric renal failure, now on CRRT. And of course, he couldn't make decisions for himself. And on rounds one morning, although I never, as a general rule, engage in conversations about whether or not we should do CPR, I find that to be missing the boat of the broader picture of goals of care conversations and typically trust degrading. But there are some cases like this one where a cardiac arrest is a foreseeable event and time was not on our side to engage in this more complete, holistic goals of care conversation. And so I was presented with a choice. First way of introducing this concept is how I, and I'm going to guess many of you, were taught to do this in medical school. Situations like this, there's a risk that his heart may stop. If it did, would he want us to do chest compressions to try and restart it? But what I found myself seeing, and what I've said every time since in similar situations, is that in situations like this, there's a risk that his heart may stop. Because of how sick he is, we would not routinely do chest compressions. Does this seem reasonable? What's the difference here? I'm setting a default that we would not do chest compressions and soliciting assent. There's no option that's being taken off the table. Patients, or in this case family members, are free to inquire why or to say, CPR. All options are fair game. But I can tell you that not once in the hundreds of times that I've done this since has a family requested CPR. They've inquired why. We've had a further conversation, but none of these patients have actually been coded. So this is the idea of a default option. Defaults are the events or conditions that are set into place unless an alternative is actively chosen. Defaults are powerful. This is one study we did recently in our health system for outpatient providers who, every time they enter a drug in the medical record to prescribe for their outpatients, regardless of whether they enter the generic name or the trade name, the generic name pops up and they can click accept. So you type in Toprol, metoprolol comes up. If you want to actually get to Toprol, you have to go through 2 other clicks and enter it again, and there you are. And you can see that this was dramatically effective in increasing generic prescription rates in our health system across all categories of drugs. This is another example from a randomized trial we did a number of years ago. You would think that, okay, I kind of get it. Physicians may not have really strong preferences about whether or not they're prescribing generics or trade name drugs, but patients have really strong preferences about the type of care that they would want near the end of their life, right? So we randomized 132 patients with advanced diseases of the chest, median expected survivals of 2 years or fewer, to one of 3 versions of an identical advance directive, except for the ways in which default options were presented. So in one version, comfort-oriented care was presented as the default, as well as choices to forego a variety of life-sustaining therapies. In another scenario, life-extending care was presented as the default, and the default was to receive all those life-extending therapies. And then there was a middle option, which you might call a standard default, in which nothing is pre-selected, such that if you don't make an active choice, you're defaulting to surrogate decision-making. So we randomly assign the patients. Here's an example of the comfort default. You can see, in this case, the overall goal of care question is framed like this. I want my healthcare providers and agent to treat me by helping relieve my pain and suffering, even if that means I may not live as long. And if you don't want that option, you just cross it out and put your initials beside one of the other 2 options. Namely, I want to be treated by helping me live as long as possible, even if that means more pain and suffering, or I just don't want to make this choice at this time. All fair game. In the life-extending default, the middle option was presented at the top and pre-selected. And in the standard default, the order of the options was randomly assigned, and none of them were pre-selected. So people complete their assigned advanced directives, send them to us, and before we upload them into the electronic health record, we call them and say, here's what we did. You got one version that had this set of defaults. Other people in this study got other versions, and their defaults were as follows. So just to make sure that we understand your actual preferences here, we're going to go through them one by one, and you tell us if you want to make any changes before we put this as a standard document in your electronic health record. Not one patient made a single change during that debriefing process. And yet, despite that, the defaults had tremendous influence. This is the proportion of people in each arm who chose comfort-oriented care. 77% did so when it was presented as the default, compared to 43% who opted out from life extension and into comfort care when life extension was presented as the default. The corresponding rate was 61% when there was no pre-selected option. Similar results for choices to forego life-sustaining therapies, far more likely to forego a feeding tube, dialysis, mechanical ventilation, ICU admission, etc., when doing so is presented as the default option. Now, I'm not saying that this is what we ought to be doing as a general practice in advanced care planning. It's an open question. We've just completed a much larger 500-person trial among a more diverse set of patients recruited from 30 clinics across the state of Pennsylvania. We don't have the data yet, but the goal of that trial is to see how we do know that similar patterns emerge in terms of influence on choice. What we don't know yet is what happens to patients in terms of survival, quality of life, caregiver bereavement outcomes, and all of the other important measures that you might want to know. And it's not until we have that evidence can we really say what we ought to be doing here. But the point I'll make is that defaults are powerful, even about choices that we think might be very deeply held, yet in fact, these data suggest are less so, and very malleable as a function of how we frame choices. Here's another example where we're using the idea of default option. This is a large 30,000-person randomized trial among 11 hospitals in Ascension Health, the largest health system in the United States, with over 160 hospitals. What we're comparing here is the standard approach to palliative care consultation for patients who are admitted to the hospital on the ward or in the ICU, where the hospitalist or the intensivist or another care provider has to identify the patient as someone who could benefit from palliative care and actively order a consult. To an opt-out intervention where an electronic algorithm, an algorithm in the EHR that we built and validated identifies patients as having consensus criteria indications for palliative care consultation, enters that order by default and gives the physicians a chance to cancel it. Otherwise, it becomes active. So these are the patients. We're looking at patients with advanced COPD, advanced dementia, and end-stage renal disease on dialysis, patient populations who are typically underserved by palliative care consultation. And here's the intervention. So like I said, patients are admitted to the hospital. We call that day 0. The algorithm starts running, and by 3 p.m. on day 1, the next day, if it identifies the patient as meeting these eligibility criteria, it enters a silent order. It's silent to the palliative care team. They don't see it yet. And for the next 24 hours, anytime the hospitalist or the intensivist or anyone else with primary authority over the patient opens the chart, they are instructed that this default order has been entered, and they're instructed on how to cancel it if they'd like to. I'll show you that in a moment. If they don't cancel it, it becomes live 24 hours later. And these are the primary and secondary outcome measures of the trial. So here's how it works, the cancellation. It's pretty simple. They have to, for those of you who use Cerner EHRs, this will probably look pretty familiar. All the hospitals in this study use Cerner. So they go to their order list, they right-click on the consult palliative care order that's been generated, and then they left-click cancel DC. They also have to enter a reason. Standard list of reasons: no palliative care needs at this time, primary care team's already meeting the patient's palliative care needs, etc. They can type in an option, but they have to enter some reason, and then they just click the green arrow, and it's canceled. So of the 11 hospitals that are in the study, 9 have already transitioned. These are data from just the first 3 that we prepared for our first DSMB meeting. You can see dramatic increases in the penetration of palliative care, more than doubling of the rates for eligible patients across all 3 hospitals. Now, why do the patterns change, or do the patterns vary across these hospitals? And I'll say these same data of doubling is held across the other 5 that have already gone live. I'm sorry, other 6 that have already gone live. But why the differences? Differences in cancellation rates. Right? This is, all hospitals have different cultures around palliative care. This is not terribly surprising. We anticipated that there would be some variability here. But even in those hospitals with high cancellation rates by the intensivists or the hospitalists or other specialists, a doubling. Big effects. But defaults are not the answer to everything. Sometimes defaults can be too strong. They're so effective that using them for broad populations of patients could yield unintended consequences. So what are some other tools that a thoughtful health system designer might use? So here's one example. This is the concept of forced active choice. And I'll show it in another advanced care planning trial that we recently completed. Will be published next month. So we took about almost 1,300 people who are going to be new employees at our health system. And as part of that onboarding process, you go through as any new employee, you fill out your W-9, you give your driver's license, background check, you make your 401k declarations, etc. We just put in an advanced care planning module. And in the control intervention, we made that module optional. We said, this is your future healthcare planning. There are 2 buttons. Two buttons. You can either complete an advance directive or confirm that you already have an advance directive, or you can just skip out. It's an optional module. The intervention, it's not optional. You've got to do something. But now what we've done is we've put that middle button in there. So now you can complete an advance directive. You can decline the opportunity to complete an advance directive, or you can say you've got one. And all we've done here is put declination on a level playing field with completion. Both require some active choice. All the options are still on the table. We haven't removed anything from the patient's choice set. They simply can't let inertia hold sway. And you can see huge effects. Almost a doubling on the rates of patients who completed advance directives online, which was the primary outcome of this study. We gave patients the option to then download it, get all the requisite signatures, and send back to us. And some did that, and there was a doubling of the rates from 4% to 8%. But we didn't require people to do that for this particular purpose. This was just a proof of principle study in preparation for a large grant that we're doing in the nation's largest nursing home system now. With about 450 nursing homes, we're proposing to do this for all patients admitted with advanced dementia, just requiring the caregivers to either engage in advanced care planning or say they don't want to. This same idea, though, has potential power in critical care. So my colleague Meeta Kurlin, who's spoken earlier at this conference, is working on developing a grant in collaboration with Mark and myself and some others at Penn, testing a variety of different nudges to augment lung protective ventilation use. So here's the idea. We know that it's a good thing in patients with ARDS. We think it's probably a good thing for patients without ARDS, but the data are far less clear. And it may be that there are some patients, particularly without ARDS, for whom it could be harmful. Many health systems, Kaiser Permanente, Northern California being one, are already moving to default LPV settings in their EHRs. We don't think that's unreasonable, but we think it's important to evaluate the potential for unintended consequences. And it may be that a lighter hammer, the active choice intervention, could be better, all told. So the way that would work, instead of just pre-populating the settings, particularly the tidal volume, based on what the vent knows about the patient's ideal body weight, you could pre-populate on the one side and then enter an opportunity to enter alternative settings on the other, and they have to confirm one or the other, right? So that would be the active choice approach. There are other times that it's not that defaults are too strong. We would love to use them, but we just can't. It's like fitting a square peg in a round hole. It's not possible. So here's one example. I think earlier in the conference, our new society president spoke about the Choosing Wisely campaign. So you may be familiar with some of these things. There are some that actually are amenable to default options. So for example, number 4, don't deeply sedate mechanically ventilated patients without a specific indication, without a daily plan to lighten sedation. So you could, and in fact some ICUs do, by default instruct the nurses to interrupt sedation infusions on a daily basis, usually in the morning, unless a physician enters an order to the contrary or communicates to the contrary. That could be done. But how about this last one? Don't continue life support for patients at high risk for death or severely impaired functional recovery without offering patients and their families the alternative of care focused exclusively on comfort. There's no way to make that happen by default. So we need some other strategies. So we're studying 2 strategies, alone and in combination, in this randomized trial that's funded by the Donahue Foundation and just launched February 1st. It's a study in 19 different ICUs in 10 hospitals in the Carolinas Health System. And what we're doing is enrolling patients who are 18 or older, who've been mechanically ventilated for at least 48 hours, and who at the time of admission already had one or more life-limiting illnesses, defined as those that confer a median expected survival of 2 years or fewer. At the time that they become eligible, if the hospital is transitioned from usual care, as shown in the white boxes, to one of the interventions, A and B, which I'll describe in a moment, those interventions become active. They're EHR-based interventions. The time at which each hospital transitions and the choice of the intervention to which they receive is all randomly determined in this stepped wedge design. And then whichever intervention they don't receive first, at some additional randomly assigned time, the other intervention is added. So we have effectively a 4-arm trial: usual care, intervention A, intervention B, and the combination. So let me tell you about the first intervention. This is not my prediction for the Final Four this year. Instead, this is one of my favorite studies by Nobel laureate Danny Kahneman, where he took patients at the University of Michigan and Ohio State, and some, did I say patients? I meant students. And then some students at UCLA and nearby UC Irvine. And he asked these students, imagine any given high school senior. Where would this senior be happier going to college? Michigan or Ohio State, or UCLA, UC Irvine, right? What do you think they said? Students at both groups of schools, those in Southern California and those in the Midwest, both predicted that that given high school senior would be happier going to school in sunny California. And yet there were no differences when they assessed the actual happiness using some scale, happiness scale, among students at either school. So this is a focusing effect. The simple contrast between the Midwest and Southern California elicits ideas of weather. And sure, weather's important in your happiness. But how much of your college happiness was determined by the weather? I'm not going to tell you all the things that made me happy in college, but I can tell you that weather was probably a small piece of it. But the way this choice was structured overemphasized the salience of weather because that was the one thing that so obviously differed. And so people over-attend to it. Or perhaps attend to it as much as they should, but more than they otherwise would. And that's what we're showing in this, or hoping to show in this study. So it's based on a fun project that I had the opportunity to work on with Allison Turnbull and Dale Needham from Hopkins, where we surveyed intensivists around the country and randomly assigned them to view vignettes of 10 different patients who had different severities of illness as assessed by their MPM model, predicted probability of in-hospital mortality. We randomly assigned the intensivists to one of 3 arms before considering each of the 10 patients. We either told them, option 2 is actually the control arm, that the patient wants life support regardless of the prognosis. Option 3 is that the patient doesn't want life support if their prognosis is bad. And then option 1 is also that the patient doesn't want life support if the prognosis is bad, but now the intensivist has to estimate the patient's prognosis. They don't have to be right, they just have to estimate it. And the outcome measure is whether they would discuss withdrawal of life support with these patients' family members. So the bad news first. The bad news is telling docs what the patient wanted, the orange versus the green, doesn't do anything. That's kind of depressing. But the better news is that simply forcing clinicians to focus on prognosis led to, on average, a 50% increase in their stated, emphasis on stated, this is not real world, this is hypothetical, but stated propensity to discuss the withdrawal of life support. So like I said, this is preliminary data. Again, doesn't tell us what we ought to be doing, but this is the intervention that effectively we're now testing as intervention A in the PONDER trial. And the way it works is like this. So once the patient becomes eligible, the doc gets this prompt. Do you think the patient will be alive 6 months from now? And if so, what do you think their functional status will be? They have to answer this question in order to sign any additional orders. That's it, though. Just 2 questions, done. The other intervention stems from this work from Daniela Meeker and Jason Doctor at USC, where they use the principle of accountable justification to change the way the electronic health record works for outpatient physicians who are contemplating prescribing antibiotics for patients with upper respiratory tract infections. So guideline discordant antibiotic use. And what they do is they, in the intervention group, they build the EHR in a way that when the doc enters an order for an antibiotic, an alert appears and says, this is an upper respiratory tract infection. Please enter a justification for why you're ordering the antibiotic. They can enter anything they want, but they've got to say something in order for the antibiotic script to actually happen. So we're using something similar in the second intervention in PONDER. We're requiring physicians to either offer the option of comfort care or justify why not. So question 1, have you offered the patient or his or her surrogate decision maker the option of care focused primarily on comfort during this stay, yes or no? If you say yes, you're done. If you say no, you got to enter a reason why. Finally, I think nudges hold great potential to improve a particularly pernicious problem in critical care and, in fact, all of public health. The fact that most randomized trials are not completed due to poor accrual. I hear you've heard some rosy data recently from the Rose trial in terms of their accrual rates. I would posit that accrual rate is still painfully slow. It's better than standards in critical care, but keep in mind that more than 50% of critical care RCTs never reach their target accrual rate. That's the same in cancer. The IOM has lamented the tremendous waste of public resources that comes from inadequate accrual to clinical trials. It's also a big ethical problem. Why? Because we're then asking patients to bear the risks and burdens of RCT participation, whatever they may be, with no real potential of its producing generalizable knowledge. So this is a big problem, and we have not come up with good ways to solve. But here, too, I think behavioral economics offers a lot of opportunity. So you can't see this table. I don't even want you to. I'll just call out a few different examples. So one is the idea of injunctive norms. Dustin Kruskinger is a fellow of mine, or mentee of mine, who's leading a study now of this approach. Series of questions that you might ask surrogates in the ICU before enrolling them in or soliciting their consent for participating in a trial. So is your loved one the type of person who would hold the door for a stranger? Right? It's just setting a mind frame of altruism. It's not changing anything. Surrogates could still say yes or no, they want to participate. Or how about enhanced active choice, similar to what I described before? Why don't we do this? Everyone reads the consent form, engages in a conversation, and then we ask, please sign here to participate in this study to help improve the care of future patients, or sign here to decline the opportunity to help in this way. All of the options are still available. We're just changing the choice architecture. How about financial incentives? A controversial approach. I don't know if we should be doing this. But I do know that it's a testable problem. And in fact, we have an R01 that's testing this right now. It's not in the critical care world. It's patients with non-operable non-small cell lung cancer who are being randomly assigned in a parent trial to undergo proton-based versus photon-based XRT. And in that trial, which has atrocious accrual, we're building in a randomized intervention where they'll get $0, $400, or $1,200 for participating. And we're assessing things like the time they spend reviewing the risk portion of the consent document. There's a preliminary study that suggests that when you offer money, patients spend more time reviewing the risk section. They're like, oh, someone's paying me. I better pay attention to this, right? And isn't that what we want? There's actually evidence that IRBs spend more time reviewing consent forms when they see that you're proposing to offer money. We kind of want that too. We're measuring, of course, the rates of accrual. We're measuring their perceptions of the risk of the trial, right? Are patients' perceptions of risk going down in the face of money? If so, that would suggest that payments are an undue inducement. Probably not something we should do. But again, there's preliminary evidence that that's not what happens. Similarly, we're looking to ask whether any given amount of money may be preferentially influential among the poor, thereby creating a justice problem. Again, early data suggests that doesn't happen, but if it did, it'd be another reason perhaps not to use this approach. But these are empirical questions deserving of evidence-based answers, not mere conjecture. And so that's what we're hoping to understand in the RETAIN trial. I've touched in that last slide on some of the ethical issues that arise in using nudges in clinical care. I have not even come close to touching all of them. There are literally dozens. They are thorny. And some of the leading philosophers in health systems across the country are really focused on this issue. These are just a few papers that we've produced that touch on some of these issues. They're not easy, but in general, it's important to remember one thing. We can't avoid nudging. Some intervention's going to be presented as the default. Some condition's going to be listed first, and all things equal, the thing that gets listed first gets chosen. There is no way to build a convention center like this without thoughtful consideration to where you put the bathrooms, whether you have escalators in addition to the stairs, or you make the stairs prettier or less pretty to attract people to use them. These are all choices in architecture, and correspondingly, how we design our EHRs and how we design other aspects of our health system are all choices. And what I'm simply positing is that we can't avoid choice or influencing choice, so we ought to influence choice mindfully with a public health goal in mind, rather than haphazardly, which is how most health systems are built. And so the task for the conscientious clinician is not to avoid influencing choice. That's not possible. But rather to avoid restricting choice. Taking options off the table is clearly not justified. But influencing choices, particularly in spaces where patients have no reason to hold deep-seated preferences, is totally reasonable and arguably morally required. Thanks very much. Be happy to take some questions.